Good evening, everyone. On the behalf of Cipla Pharmaceutical, I, Kumar Kaushal, with my colleague Faisal, would like to welcome all the doctors in this meeting. Today's meeting is going to be a Rheuma-Derma interface meeting. For that, we have with us Dr. Poonam Jalan and Dr. Arghya Chattopadhyay. Dr. Poonam Jalan is a renowned senior dermatologist from Kolkata with over 17 years of experience in dermatology medicine. Ma'am has received several awards and recognition for her work in the field of dermatology. Today, ma'am will be speaking on the topic plaque psoriasis and its management. Next, we have with us Dr. Arghya Chattopadhyay. Sir is working as a consultant rheumatologist in Kolkata and has experience of more than 10 years in this field. Sir has completed DM Rheumatology from a prestigious institute, PGI Chandigarh. Sir will be speaking on the topic Psoriatic Arthritis and its management. So without making any further delay, I would like to invite Dr. Poonam Jalan to please enlighten us with your knowledge. Ma'am, over to you.
Thank you so much, Kumar. Good evening, one and all. First of all, I would like to give my sincere thanks to Cipla to give me this opportunity to talk today. And as we all know that psoriasis is a very important dermatological condition which we see in our daily day-to-day OPD. And we'll be just talking about chronic plaque psoriasis, clinical features, and the management part. So as we all know, psoriasis is a chronic, autoimmune, non-communicable disease which can cause disabling arthritis, which highly impacts patients' quality of life. It is characterized by raised, well-demarcated, bilaterally symmetrical, erythematous scaly plaques. If we look at the global burden, it's around 2% of the world's population is affected by psoriasis, while in India, if we see around 25 million patients are affected. If we look at the male versus female ratio, it's male which are being affected more than female, approximately 2 times. And as I already said, it really impacts the quality of life. If we look at the etiology, there are genetic factors, environmental factors, and immunological factors. If one of the parent is affected, there are 16% chance that the child will have may have a psoriasis. And if both the parents are affected, the chances increases to 50%. Environmental factors are the trigger factors, and it can be drugs, sometimes infection, physical trauma, and even psychological stress increases psoriasis. If we look at the skin in psoriasis, what we will see that compared to the normal skin where the keratin layer is plain, we will have inflammatory plaques, and these are adherent silvery scales which are very characteristic of psoriasis. So what is the pathogenesis? How this increased scaling and this thick inflammatory plaques happens in the skin in psoriasis? So as we discussed, there are triggers like microorganisms, environmental stress, or there could be genetic susceptibility. This leads to production of pro-inflammatory cytokines like interferons and TNF-alpha. It can also it activates the plasmacytic dendritic cells, causing production of Th1 and Th17. Which Th1 and Th17 cells goes and affects the myeloid dendritic cells, and there is differentiation of the keratinocytes which increases. So this inflammation, plaque formation, T cell migration, angiogenesis, keratinocyte activation, proliferation are the main key in the pathogenesis of psoriasis. And why the pathogenesis is important? Because now in the era of target specific treatment, we are targeting these cytokines, these interleukins, and these pathways to be very specific to the molecule which goes and treat only the psoriasis. So if we look at the clinical features, the psoriasis is divided into morphological based classification, and it is also a location based. Generally, the psoriasis is a plaque psoriasis, which is the classic thick crust scaly plaque, but it can be guttate, which is small plaques. It can be erythrodermic, it can be pustular. Generally, psoriasis is found on extensor aspects of the forearms and legs, but then there is another psoriasis, which is inverse psoriasis. It could be affecting only palms and soles, causing palmoplantar psoriasis, or nails, causing nail psoriasis. Many a times there is overlap in the clinical features, and the one form can change to another form. So as we already discussed, these are the clinical features of different types of psoriasis. This is a photo of plaque psoriasis, where we can see how thick and classically crusted plaques are presented bilaterally symmetrical. We can see there is a lot of erythema, lot of scaling, and silvery scales. this is gutted psoriasis, where we can see the size of the plaque is very, very small. So when there are multiple small erythematous plaques, it is a form of psoriasis known as gutted psoriasis. In pustular psoriasis, there will be pustule formation. When the body surface area is affecting more than 80%, it is erythrodermic psoriasis. And when it is the flexures like the underarms or the groin area or the folds, it is an inverse psoriasis. So what are the symptoms of psoriasis? Classically, there will be, as we saw, there will be scaling, there will be erythema, there will be itching, and 42% of patients also have joint pain. And then other manifestations like burning, bleeding, pain in the skin, physical discomfort, and all other features. Now, there are particular sites like scalp psoriasis, which is the most common form, and it is frequently the first site of the disease involvement. Any patient presenting with psoriasis, we always ask, is there any involvement of the scalp? Nail is an important window to the skin diseases, and in psoriasis also nails are affected with oil drop signs, subungual hyperkeratosis, pitting. The nail psoriasis is very difficult to treat. It is associated with functional impairment, pain, and reduced quality of life. Palmoplantar psoriasis is difficult to treat, and as hands are very commonly used to, to eat food, to shake hands, it significantly impacts the quality of life when hands are affected. Psoriasis is not a disease of the skin only. It also affects multiple organs, and that's why it is associated with multiple comorbidities. Psoriatic arthritis is one of the most common comorbidity, which is very disabling and painful to the patient. Other common comorbidities are obesity, diabetes, dactylitis, metabolic syndrome, enthesitis, cardiovascular disease are also associated manifestations. As per an Indian study, 32% patients have at least one comorbidity, while 10.8 have two, and 8.5 have more than three comorbidities. Now, what is the impact of psoriasis on quality of life? We know that psoriasis is visible to everyone around the patient, and it greatly affects the quality and psychology of the patient. The patients get affected physically, emotionally, and the well-being of the patient is also affected. We see many a time the patient going into depression, fear, embarrassment, and anger because of the skin condition. I have seen many patients getting divorced because of the psoriasis. Some mothers not able to plan a child because there are multiple social factors as well affected with psoriasis. So if we classify psoriasis according to the severity, it is mild, moderate, and severe. When body surface area and PASI is less than 3% and the global assessment of investigator is equal to 1, it is a mild psoriasis. If there is 3 to 10% body surface area involvement and the PASI between 3 to 10 with 2 IGA score, it is moderate psoriasis. And if BSA, which is body surface area, more than 10%, PASI, which is a calculation skills, psoriasis activity index, is basically depending on erythema, scaling, and thickness of the plaques. When it is more than 10 and IGA 3 to 4, it is a severe psoriasis. And the treatment of the psoriasis, it is important to know this classification of severity, because the treatment which we decide clinically depends on whether the psoriasis is mild, moderate, or severe. So as we said, PASI is an important tool to assess the severity, and PASI has three features in it, which is erythema, scaling, and thickness of the plaques. The treatment is targeted depending on the PASI score. PASI 75 means a person's PASI score has decreased 75% from baseline, and PASI 90 or 100 means 90 to 100% reduction in the PASI scores respectively. So PASI score is the treatment goal whenever we are talking about treatment of psoriasis. The score of PASI ranges from 0 to 72. This is a visual representation which we can see that how PASI is calculated. These are the areas in which we calculate the body surface area involvement. This is the erythema, this is the thickness or induration, and this is the scaling, how we give the scores are represented over here. As we said, it is very important to classify mild, moderate, and severe because it affects the management of psoriasis. So generally, when patient presents with mild psoriasis, according to the guidelines, we generally try to treat with the topical treatment. It could be a topical corticosteroid as a first line of treatment, or it can be a vitamin D analog like calcipotriol. Phototherapy, narrowband UVB is also a very good treatment option. However, if the patient is having moderate to severe psoriasis, then we think about the systemic treatments, which can be conventional medications or it can be biologics. with or without phototherapies. So what are the first line label treatment for moderate to severe psoriasis? If we look at the conventional medications, it is methotrexate, which is one of the most commonly and the oldest medication for psoriasis. And the others are acitretin, cyclosporine, and fumarates, though fumarates are not available in India. If patient is having inadequate response, has contraindication, or if the conventional medication are not tolerated, or if there are indications like difficult to treat areas, it is affecting the quality of life, and the other indication which I'll be talking, we can also start first line biologic agents, which are mostly TNF alpha inhibitors and interleukin 17 inhibitors and interleukin 23 inhibitors. So there are also treatment with second line label, which can be tried when the first line label are not working, or if you want to add on the treatment. So now the question comes, why biologics for psoriatic disease? So as I was saying, that our treatment goals have changed. Previously, we used to talk about PASI 75, but since the introduction of biologics, we are now talking about PASI 90 and PASI 100. Because initially in 1950s, when the pathogenesis or the pathway for psoriasis was evolving, and we were knowing what are the reasons for psoriasis, we were targeting the molecules in a broad spectrum manner. And that time, the treatment was started with methotrexate, and then PUVA came, acitretin, cyclosporine. The changes came in 2000 with the introduction of etanercept, and after that, the whole scenario has changed. And now we are targeting each molecule one by one, and we are trying to be as narrow and as target specific as possible. Conventional immunosuppressants, as we all know, methotrexate, cyclosporine, acitretin, and apremilast, they have efficacy by the week of 16th week, and they have efficacy of around 36% to 33%, except cyclosporine, which has a 65% efficacy, which clears or almost clear by week 8. However, the adverse effects and consideration with conventional medications have to be kept in mind. As methotrexate, we all know, can cause hepatotoxicity in long term, can affect the lungs, can cause pulmonary fibrosis, and is contraindicated in renal insufficiency. Cyclosporine can cause hypertension, hypomagnesemia, hyperkalemia. Apremilast is a new molecule comparatively and have to be found sometimes worsening of depression. GI disturbances are very common, because of which many times I have to stop apremilast for my patients. Acitretin is contraindicated in women of childbearing age because of teratogenic nature. It can also cause xerosis, sticky skin, and hair loss. So what are the advantages of biologics? Now, biologics, first of all, have good control over symptoms. It has long-term remission. It improves the quality of life. There is high efficacy and favorable safety. It improves the prognosis. It has revolutionized the management of psoriasis. However, cost is an important factor which we have to keep in mind while talking about the biologics to the patients. Various guidelines define treatment success as clear or almost clear, like more than 90% improvement in the PASI. So it's been found that patients who have achieved and PASI 75 still have impaired quality of life. PASI 90 to PASI 100 response lead to a greater improvement, and patients achieving PASI 90 to PASI 100 have DLQI score of 0 compared to the patients achieving PASI 75 to less than 90. This making that probably we should also offer biologics to our patients where it is indicated. So what are the criteria, or when do we consider that the patient is eligible for biologics? So any patient who is having severe disease like PASI more than 10, BSA more than 10, or DLQI more than 10, or patient who has contraindication to systemic therapy or phototherapy, who is unresponsive to the treatment, who has severe unstable life-threatening disease, the patient with comorbidities like psoriatic arthritis, with severe pustular or erythrodermic psoriasis, area of high impact like palms, foot, genitalia, should be offered biologics even as a first-line treatment. Now we all know biologics and we know the target molecules. We know that TNF inhibitors, which were introduced for are mostly adalimumab, etanercept, infliximab, and golimumab, which can be used both in psoriasis and psoriatic arthritis. Interleukin 17 are also used in both, and anti-CD6 itolizumab is, however, mostly only for the skin psoriasis. As we said that now we are targeting the inflammation pathway. This is a visual representation which says that at which level the molecules are working and how the biologics are going and affecting on that particular area. As we can see here, see the keratinocytes, and we can see these are the molecules and how anti-interleukin 17 therapies work directly to the inflammatory cascade. TNF alpha is a pro-inflammatory cytokine which is at the apex of all inflammatory If we see, TNF works on macrophages, endothelium, hepatocytes, sinusocytes, osteoclasts, keratinocytes. And that's why when we are targeting TNF alpha, we are not targeting only the keratinocyte, we are targeting all these molecules as well. That's why TNF alpha inhibitors are used in dermatology, rheumatology, gastroenterology, as well as in ophthalmology. Here we can see when etanercept was approved for psoriasis and psoriatic arthritis, it is also been used for many gastrointestinal disease like Crohn's disease, ulcerative colitis, and also has been used for ophthalmological problems along with rheumatological and dermatological issues. We have also heard something called biosimilars. So what are biosimilars? So biologics are generally the drugs which are produced from living organisms, and it contains component of living organisms. While biosimilars are designed to have the active properties similar to the biologics, but they are not from the living organism. Similar are less costly, but there is no clinically meaningful difference in terms of safety, purity, and potency. And due to complexity, biologic products can only be made that is similar, but identical to it cannot be made. And TNF alpha inhibitors have many biosimilars which are available in the market. So etanercept and adalimumab are used in arthritis as well as psoriasis in adults as well as in children. These are the doses. Like etanercept can be given for the skin. I will be talking. Starting can be given 50 mg twice weekly for 3 months, and then 50 mg once weekly as a maintenance in adult. Adalimumab is given as induction 80 mg on day 1, and then maintenance is given 40 mg every other week, starting first week after the initial dose. Generally, up to the 16 weeks, the continued therapy is given. Now, and if the patient does not respond by 16 weeks, then it has to be considered whether the medication should be continued or it should be changed to something else. Etanercept efficacy in psoriasis, multiple studies have been done, and it has been found that 49% patients achieve PASI 75 in all the studies almost. Now, if we come to adalimumab, we see that adalimumab works very fast. By the 16 weeks, we see there is significant improvement in the PASI score, if we see at this graph. And if we compare psoriasis PASI in biologic naive and biologic non-naive patient, we see there as well, there is significant p-value showing a significant improvement by week 16 in all patients receiving adalimumab. So it works really fast. What about the relapse once we discontinue the treatment? And it shows here median time to relapse in weeks, and we see that in adalimumab it takes around 24 weeks for the relapse to occur. Now, if we are planning TNF alpha inhibitors, what are the blood tests or what are the monitoring which you need to do? What is the history we need to take before we start anti-TNF therapy? So we have to rule out any active infection. So ask for fever, any lymph node disease. You have to rule out any malignancies, any signs of decompensated heart failure, any signs of autoimmune disease or demyelinating disease have to be ruled out during physical examination. The mandatory biological test before starting anti-TNF therapy is we have to look for tuberculosis, particularly because India has such a high incidence of tuberculosis. 1-2 test and quantiferon TB gold test can be has to be done. In case of doubt, chest X-ray needs to be done. Serology for hepatitis B, C, and HIV. We have to do lab parameters which are very basic, like complete blood count, liver function test, and creatinine. Urine analysis, kidney function test, pregnancy test, ANA has to be done before we start TNF inhibitors. During the treatment, the monitoring is required. We have to look for the disease activity. We have to calculate repeat PASI scale after a few weeks. We have to look that there is improvement in arthritis or not. We have to focus on malignancies and risk factor for serious infections and look for it while the patient is on treatment. Post-treatment, after discontinuation, patient should be followed up with medical history and physical examination. The precautions for use are for demyelinating neurological disease, for interstitial lung disease, systemic autoimmune disease, malignant disease, and recent vaccination with live attenuating disease. It is totally contraindicated in patients with hypersensitivity to active ingredient, in patients with active tuberculosis or with severe sepsis or with opportunistic infections. Patients with moderate to severe heart failure are also contraindicated to receive TNF inhibitors. Now, the new molecule which has come into picture is recently JAK kinase inhibitors, which are also being used. Though JAK inhibitors are not FDA approved for treatment of psoriasis, however, we are talking about it generally because we have been using them recently. So here we see this is a pathway, and we see here JAK is used. It is there in the pathway for the psoriasis. Cytokines, interferons also play significant in psoriasis pathogenesis. And apremilast, which is also a new molecule, is phosphodiesterase inhibitor, and we can see here for apremilast how it goes and affects the keratinocytes and TS17 cells. So many studies have done for tofacitinib with 5 milligrams once daily or 5 milligrams twice daily, even with 10 milligram BD doses. And it has been found in all the studies, in OPT studies, that the patients who have been receiving tofacitinib had good improvement in the PASI. And the patient maintained PASI 75 response compared to the placebo. These are the pooled data analysis which shows the efficacy of tofacitinib. And we see there is significant high proportion of patients achieving PASI 75, 90, NAFSI 75, and DLQI score with tofacitinib 5 mg or 10 mg BD versus placebo. From here onwards, Dr. Arga will be talking about the psoriatic arthritis, and he will carry on. Thank you so much for patience hearing.
Very good evening to everyone. And first of all, I would extend my sincere thanks to the team CIPLA for creating this opportunity, and excellent talk by Dr. Poonam Jalan. So what I will be taking you through psoriatic arthritis, and so I will try to be as brief as possible, and at the end we may plan for more Q&A session. So psoriatic arthritis, as we all know, so psoriasis is more like a multi-system disease. As Madam told us, it's a chronic immune-mediated disease which is not limited to the skin, which can also affect joints. Like it can classically, this is combination of what we call broadly, we have two different type of arthritis. One group of arthritis which involves the axial spine, one group of arthritis which involves the peripheral joints. Psoriatic is one disease which can practically affect both the joints. It has a like prototype of the peripheral arthritis is rheumatoid, prototype of axial arthritis is ankylosing spondylitis. But psoriasis is only the disease which can have the ability to affect both the axial spine and the peripheral joints. But it is not just limited to the skin and joint. It can also affect the enthesis, which is called enthesitis. It can create something very unique for this disease, which is known as dactylitis. It can have it can affect the nails. And one more thing is missing here, like it can also affect the eyes, which is called uveitis. So it's a multi-system, multi-organ disease. It's a chronic immune-mediated multi-organ disease, which has an ability to affect cutaneous manifestation, the joint manifestation, enthesitis, dactylitis, nail changes, and uveitis. So if Madam has already talked about the burden of the disease, is more related to the psoriasis, but the psoriatic arthritis is also somewhat prevalent, 0.04 to 1.2%, and it varies from area to area. We don't have our Indian data in a large scale, but it's again, majority of the autoimmune disease, as we know, are more female dominant. But in this case of spondyloarthropathy group has one of the exception where most of the patients are either male dominant or there is a male is to female 1:1 ratio. And the usual age of onset is in between 30 to 50 years, but definitely there are evidences of child psoriasis. So what is the usual trend of developing arthritis in a patient with psoriasis? So majority of the patients has pre-existing skin disease who later develop arthritis. Around 15% develop simultaneously, both the cutaneous and joint manifestation. And 15% cases, this is very important to know for who are dealing with arthritis, 15% cases of psoriasis cutaneous manifestation can occur after the joint involvement. So in that case, diagnostic dilemma is a very major issue, because patient used to complain of classical inflammatory arthritis with either maybe peripheral involvement or axial involvement, but all the reports turned out to be negative. So this is our very common experience, like patients are suffering from arthritis, but as patient getting tested for rheumatoid factor, anti-CCP, ANA, they are getting tested for HLA-B27, they are, so everything turned out to be negative, but patients have a very classical history for inflammatory arthritis, and as all the reports are negative, patient is not getting any treatment. So this will be very important clue if the history of classic inflammatory arthritis involving either axial or peripheral joints, or in combination of both axial and peripheral, if there, then one should ask for psoriasis, because many a time we had experience that patient don't tell the history who don't have a florid psoriasis. Some of patients have, where there are some hidden areas for psoriasis, so don't bother for that, and they don't connect, patient usually don't connect the psoriasis with the arthritis. So we need to ask upfront whether there is any kind of cutaneous skin rash anywhere in the body, especially in the hidden areas behind the ears, scalp. So we need to ask for that, and many times we get there's a florid psoriasis is there, and we that makes it easy to make the diagnosis of psoriatic arthritis. So the cutaneous manifestation, the skin psoriasis, typically manifests prior to the articular disease. The lag time from onset of psoriasis and psoriatic arthritis on an average 7 to 12 years in different literature. And nail dystrophy considered to be a clinically significant predictor for psoriatic arthritis. So those who have more nail involvement, they have more DIP dominant arthritis. And so psoriatic can have various types of arthritis. One is DIP dominant, and DIP joints involvement is one of the very important differential for psoriatic arthritis. So nail involvement can predate the involvement of the DIP joints. So, and axial disease affects up to 25 to 70% of psoriatic arthritis patients, and majority of them are HLA-B27 negative. So this is the transition, like autoimmunity don't develop overnight. So there has to be a long run process. So it may be even here, as I'm talking on psoriatic arthritis, I'm starting with psoriasis because majority of the patients has preliminary psoriasis, then they develop into psoriatic arthritis. But even the cutaneous manifestation is also an immune mediated manifestation. So there has to be something like this before the onset of the cutaneous manifestation of the psoriasis. So if someone having psoriasis, then they have preclinical psoriatic arthritis. When the immune system are directed to involve not just only skin, they start affecting the enthesis, they start affecting the other periarticular structures. So in that point of time, patient can have occasional aches and pains, inflammatory in nature, involving the enthesis, or sometimes can have dactylitis. So next stage is subclinical psoriatic arthritis. So there is inflammation. You can detect inflammation, like you are getting an history suggestive of inflammatory arthritis. There is raised ESR-CRP. So, but there is no classic arthritis which we found in psoriasis. And then prodromal phase, then the classic psoriatic arthritis moves. So when we are calling someone having psoriatic arthritis, which is that phase is very classical psoriatic arthritis, that's classical having inflammatory arthritis involving the classic joints with other manifestations. So that's a very classic phase, and we call it psoriatic arthritis because they satisfy some of the clinical criteria which we made for diagnosis. So the important point is we need to pick up the cases before the onset of the disease. At least we had to build a suspicion. If someone having inflammatory kind of arthritis, if someone having recurrent enthesitis, recurrent dactylitis is a very important clue for diagnosis of psoriatic arthritis. We have seen patients initial 2 years, 3 years, just recurrent dactylitis. Then we got they developed florid arthritis, and then psoriatic skin manifestation. Even we seen patients only repeated dactylitis, and There are some psoriatic patches in some of the hidden areas. So dactylitis could be a very important clue for diagnosing psoriatic arthritis. So these are the, as we all know, what we call inflammatory arthritis, the joint pain with the morning stiffness is a very classic criteria for inflammatory arthritis. It is not just morning, anytime someone take rest, a prolonged rest cause stiffness, and it's an arbitrary time domain, like 30 minutes we consider is a significant, because there are some disease which can sometimes mimic inflammatory arthritis, which usually don't last stiffness for such a long time. So as we are discussing, it involves the psoriasis, the cutaneous, skin, and nail. This is the nail have different types of involvement. So it is one of the disease which can have a DIP dominant, distal interphalangeal joint dominant arthritis. Dactylitis, what we call sausage disease, like the entire digit becomes swollen and painful and tender. So it is not just the joint involvement. In case of arthritis, we have swelling of the specific joint. Like if we see the distal interphalangeal joint involvement picture, so there is swelling specifically to the DIP joints. But if you look at the dactylitis picture, there is swelling of the entire digit. So this is not the inflammation of just the joint. It also involved the periarticular structure. So entire digit got involved due to inflammatory process, and there is a pain and swelling of the digit. And enthesitis, this is very classic site for enthesitis, but there are many sites for enthesitis where we usually look for enthesitis. Practically any area where muscle got inserted into the bone and which you can palpate, that is a site for enthesitis. And one of the very common example, like we often call, I had a tennis elbow. So the tennis elbow, even a tennis elbow could be a very important clue for psoriatic arthritis. If someone is having recurrent classic inflammatory kind of arthritis, so that could be an enthesitis at that point, which we often call very casually the tennis elbow. So that is also a site for enthesitis. So even tennis elbow could be a clue for future psoriatic arthritis. So how do you recognize psoriatic arthritis? There has to be clinical features, and clinical examination is the most important part, because as I mentioned, that lab will not give you very important clues until you have a very classic disease. Lab will give you only raised inflammatory markers, only raised ESR and CRP, nothing else in the initial phase of the disease. So clinical history is a very important for diagnosing psoriatic arthritis. If you are not getting classically all the reports are negative, like rheumatoid factor, anti-CCP, HLA, all the reports are negative for psoriatic arthritis. So in that situation, one should think of psoriatic arthritis where there is a very classic symptom for inflammatory arthritis, especially if it is along with enthesitis and dactylitis. So in this situation, early phase, you will get only raised inflammatory markers. Over time, there are some imaging modalities which can help you, like if it is a damaged joint, there are some classical radiology changes for psoriatic arthritis. If even you can detect very initial phase of inflammatory arthritis by ultrasound, that is a very good modalities of detecting inflammatory arthritis these days. So these, what we are discussing, like enthesitis, nail psoriasis. So these are the windows one should start thinking of: someone having recurring enthesitis at different sites, someone having nail changes. So that could be an predate for, or this early clue for patient is going to develop arthritis. So in this situation, if patient has not developed arthritis, you may not change your medicine, or you may not start any medicine if there is no other, like if there is no cutaneous manifestation, but you should educate your patient for this. And one very important thing for history is family history. Many a time you will get a positive family history of psoriasis, and psoriasis runs in family. So that could be a very important clue for diagnosing psoriatic arthritis. So these are the sites. This is the tendo Achilles site, is a very classic site for enthesitis, and there could be even tendinitis. So inflammation of the tendons also there. So these are the different modalities for assessing the enthesitis. Like you can clinically, you can palpate, or there will be tenderness. The sites, what we do in our day-to-day clinical practice, we palpate the areas where we want to look for the evidence for enthesitis, USG is a very good modality and it can be used in your day-to-day practice. So there are the classical changes in enthesitis and USG, and that is gaining very popularity in rheumatology for assessing this kind of thing. And definitely MRI will give you, but sometimes it is not that cost effective for assessing enthesitis. So ultrasound in that case, if you're not very sure, ultrasound of the area, and you have to mention specifically that you want to look for what exactly, otherwise the assessor may miss the thing that they might look into joints onto and that will give a normal report. But if you mention that you are trying to looking for evidence of enthesitis, then they will specifically look for the evidence of enthesitis in ultrasound. So these are the some classic pictures for DIP dominant arthritis. And if you can look very carefully, what we are discussing in the left panel picture, in the left hand index finger, the entire finger is swollen. That is the evidence of dactylitis. But rest of the fingers, you can appreciate only the DIP is involved and swollen. So those are arthritis, which are swollen, and DIP is the arthritis of the DIP. But the left index finger, the entire index finger is swollen, and you cannot demarcate any of the joints in between. And you can appreciate that compared from the just side finger, that there is quite swollen and there is entire digit is swollen. So that is the very classical image of dactylitis. So these are some clinical criteria. So very important point is when you are suspecting psoriatic arthritis, it's very important to have family history, because many a times patient, especially those who, the 15% of patients, those who have the initial presentation with arthritis and then later they develop psoriasis. So especially those patients, it becomes very helpful if a positive family history and all the classic clinical symptoms will help you to get the diagnosis of psoriatic arthritis. And these are some classic radiological changes. And these days, we don't want to see these kind of pictures, because with the invent of all this advanced medicine, we hardly see, who usually take regular treatment, hardly see this kind of deformities. Like when we used to be student, there are several cases of mitral stenosis due to rheumatic heart disease, but hardly these days you will find any case of mitral stenosis due to rheumatic fever. So this is like rheumatology, era of rheumatology is also changing with the invent of all new medicines. So these are the very classic radiology. And problem is those who are not very adherent to the medicine, problem occurs mostly with them. There are some percentage of patients in every discipline, like they are very resistant to response with any kind of therapy, but majority of the patient respond very well with the new therapies. This is one of my patients, what we published in one of the journal. So this is very classic radiology, and for the classic hand picture of the psoriasis and classic radiology for psoriasis. So USG, what we are talking, like USG can be very important tool for early diagnosis, because it can give you an idea regarding the inflammation in the joint, what we call synovitis. It can give an idea regarding the enthesitis. Even in dactylitis, USG is useful. So especially in a setting of all classic markers negativity in a patients with a very classic history of inflammatory arthritis, where you are not getting classic psoriatic rash, or neither you are getting a family history of psoriasis. So in that situation, if you can document inflammatory arthritis by ultrasound or enthesitis, you can plan your treatment, because all these are immune-mediated injuries. So treatment, that is a good part, that if there is immune-mediated injury like chronic inflammation, and the USG can detect some of the features which are very suggestive of chronic inflammation, you can start treatment in those patients. So this is another, there are some studies which have shown, like what I was talking previously, like enthesitis and dactylitis could be very important clue for future development of enthesitis, especially those who have negative of other markers and other classic clinical features. So this 2.1 should remember, like someone having recurrent enthesitis or recurrent dactylitis, that could be a very important predictor for future development of psoriatic arthritis. So these are the various points where we used to assess for enthesitis. Like tendo Achilles, almost everyone know, but my important point for discussing, like lateral and medial epicondyle. So we often get diagnosed to 2-3 areas, like these areas and the supraspinatus area. These two areas, like anyone having shoulder pain, they call, I have a frozen shoulder. So every pain in the shoulder is not a frozen shoulder, and every pain in your elbow is not a tennis elbow. So this is, and another misconception regarding the plantar fascia insertion of enthesitis. So the patient usually tell, I have a pain because there is an increased growth of the bone there. My doctor has told me there is extra documentation of this increased growth of the bone, and that is causing the pain. But it is not the fact. Fact is the abnormal bony proliferation is there due to repeated inflammation. So as like for axial inflammation, there is what we know as bamboo spine. So there is abnormal calcification or bony calcium deposition in various areas where there is a chronic inflammation. So the whatever bony spicules here you can appreciate in the X-ray is not the cause, but the effect of the enthesitis, chronic recurrent enthesitis. So if you're having plantar fasciitis, if someone making a diagnosis of tennis elbow or golfer's elbow, if you're making a diagnosis of frozen shoulder, think twice if there is no other features like frozen shoulder if patient is not diabetic. And especially in this situation, ultrasound is very helpful for making the proper diagnosis, whether there is, because ultrasound can very beautifully depict all these inflammatory changes like enthesitis, arthritis, and vis-a-vis if there is any feature suggestive of adhesive capsulitis, which is called frozen shoulder. So these could be very important early clue for diagnosing psoriatic arthritis. So what could be the contributing factors for the psoriatic arthritis? So it's more theoretical. We all know the autoimmune disease are not genetic disease. So there has to be some genetic component, but it's not just a genetic component, but all the spondyloarthropathy group has a very strong family history or a very high risk of running in the family, and psoriatic arthritis or psoriasis, one of those disease due to the HLA linkage, strong HLA linkage. So they usually runs in the family, but it not just only the genetic factors. So there has to be some other immunological factors which actually got triggered by the different environmentals and other local tissue factors. So ultimately there is aberrant immune system activation in a background of genetic risk factors, which further get modified by the environmental risk factors and local risk factors. So this is in short the pathogenesis. And as madam was talking about, there are all different kinds of cytokines which get produced due to aberrant immune activations. An important point to know all these things, because these days we can target all the major areas of signaling pathways. Like we have medicine for IL-17, we have medicine for CMAP, we have medicine for JAK, MAP kinase. So all this area we can target for treatments, and these are very useful for targeting therapies. So these are the various medicine. I think those who all are treating psoriatic arthritis or psoriasis, everyone is aware of the TNF. Madam has discussed in quite detail of TNF inhibitors. IL-17 and 23 are very specific for and very useful, especially for the cutaneous manifestation. They are also good for the arthritis also. So I'm not going to discuss in details PASI and DAPSA. So these are more like in research setting, but one should at least use some of the clinical markers for the assessment, like at least one should do for the tender and swollen joint counts. At least few of the basic thing, like someone can assess with the ACR 2050 So these are the very useful markers. Otherwise, it will often become very difficult to assess in subsequent visit whether the drug is working or not, whether you should continue the drug, whether you should add on or switch to other medicine. So that planning will be dependent. If you don't use any of the basic assessment, so it will be very difficult to make that changes. So these are the treatment options. Like for psoriatic arthritis, it's good part that FDA has already approved JAK inhibitors for psoriatic arthritis. And like methotrexate, there are some changes in recent concept in for methotrexate, like still in some you can get in old textbooks, like methotrexate is contraindicated and it is one of the harmful for developing fibrosis, especially lung fibrosis. So that concept is getting changed in last 4 or 5 years, so that methotrexate is not exactly the for causative for the lung fibrosis or ILD in a setting of either psoriasis. It's not, it's caused more in a setting of rheumatoid. So it is more due to the primary disease which cause the lung problem. And if you don't get a good control over the disease, there will be more lung fibrosis than what exactly methotrexate does. So these days, even someone having a lung involvement with rheumatoid, though it is not the part of this discussion, but the issue was raised in some of the previous slides. So I am telling that even rheumatoid with ILD, we can continue methotrexate. So that is not the problem with methotrexate these days. So these are the different options like TNF inhibitors, IL-17, and this is anti-CD6 is one of the very new, possibly very soon we'll get in Indian markets also. So these are the options, and they have specific, there are lots of trials, etanercept and all this TNF has been discussed very largely by madam. So definitely TNF-I inhibitors are very effective for psoriasis and psoriatic arthritis. And these are some of the recent guidelines. So anytime, so as this is an arthritis guideline, so it depends on whether it's a mono or oligoarthritis or polyarthritis, and whether this is enthesitis or predominantly axial disease. So as psoriasis can have both the components, which I was telling in very previous slides, like it can have a classic rheumatoid-like presentation, it can have classic angst-like presentation. So if it is affecting more the axial thing, enthesitis and predominantly axial disease, so many a time these classic conventional synthetic DMARDs like methotrexate and sulfasalazine may not be very good options for them. So because enthesitis, dactylitis and axial disease, you most of the time don't respond very well to conventional synthetic DMARDs. So in that case, you may plan upfront if there is very severe disease, definitely you should give a trial of it, because rest of the medicines are quite costly. But definitely you should give a trial for the conventional synthetic DMARDs. So methotrexate, leflunomide, sulfasalazine, like rheumatoid for the peripheral joints, you can plan for it and you can assess for improvement every 3 months. If it is doing well, then you can continue for at least next 2 visits. If it is doing again persistently doing well, then you can plan to step down even your conventional synthetic DMARDs. And if it is not doing well, then you will have to shift to next phase, like you can start with small molecules like JAK inhibitors these days approved for the psoriatic arthritis, and or other ways you can plan for biological DMARDs. So, and this again, if some DMARDs is not working, the biological DMARDs is not working, then you have to shift to other mechanism of action of other group of biological DMARDs. So this is in short, and GRAPPA, you all know, this is the dedicated society for psoriatic and psoriatic arthritis. And so they have given more clear idea like peripheral arthritis, axial disease, enthesitis, dactylitis. So you can appreciate the bold thing are more important for this. Like for dactylitis, enthesitis, you can try with methotrexate. Definitely one should try with, because there are some patients who respond to the conventional synthetic DMARDs, but majority of the patient don't respond to the. So in that case, you may plan for other medications. And Many a times it is associated, we are discussing uveitis, and definitely for uveitis, there are some issues with etanercept, which is otherwise very good for psoriasis and psoriatic arthritis. But etanercept, the initial few trials has shown etanercept has practically increased the risk of uveitis and for the IBD also. So you cannot use etanercept in those situations. Those are having inflammatory bowel disease and uveitis in a setting of psoriatic arthritis. So these are in summary, like this is a few points to very important to remember, like TNF inhibitors. There were trials initially even for heart failure, because it was shown that in a heart failure, TNF got increased, but those trial ultimately leads to more death in that group. So trial was prematurely terminated, and from then TNF inhibitors are contraindicated in congestive cardiac failure. And definitely neurological issues madam was discussing, methotrexate and leflunomide, fatty liver disease, because there are chances of hepatitis and liver fibrosis. And definitely any of the DMARDs you cannot use with an active hepatitis B or C. So you'll have to treat the disease, or you will give and keep the patient on prophylaxis for hepatitis B. Then only you can use all the medication. Otherwise, there will be multiplication of the hepatitis B and C, and that will cause more problem. With this, I'd like to thank you. And if there is any question, I'll be happy to answer. At least I will try to answer. Over to the team.
Thank you very much, Dr. Poonam, Dr. Arga, for presenting the slides. Sir, there are a few questions. In the right side, you can see 3 dots. If you will click on it, it will open the chat.
Right side.
3 dots are there.
On my screen?
Yes, sir.
Mute, stop, blur, pin. I can see chat below.
Yes, chat. You can open the chat.
But I can't find any question there.
You don't find any question?
Not even in the Q&A part.
No, I can't see any questions, Kaushal. So,
team, can you please help? I can see the questions, but doctors cannot see.
Yes, actually, I've sent it to you personally. I'll send them again.
Yeah, please send it in the group so they can also see the questions.
Did you get the questions?
Yes. I think first one is for madam. How plaque psoriasis is different from the other type of psoriasis?
Yeah. Plaque psoriasis is different from other type of psoriasis. As we said, that psoriasis is classified depending on the morphological types. Other types of psoriasis means there can be pustular psoriasis in which there will be pustules, and it is generally more severe form of psoriasis comparatively when it is a generalized pustular psoriasis. And then there is erythrodermic psoriasis, which is like more than 80% to 90% body surface area is involved, along with erythema, and it is an unstable form of psoriasis. Then, depending on the site of involvement, like plaque psoriasis is generally on the body part, but when it is a nail psoriasis, when it is a palmoplantar psoriasis, so treatment-wise, it's not different. It is just a morphological classification or the classification depending on the location, which differentiates plaque psoriasis from other types of psoriasis. How is plaque psoriasis diagnosed? It's a clinical diagnosis. Most of the times we diagnose psoriasis clinically. It's very rare that we do a biopsy for psoriasis. And the factors to be considered while creating a treatment plan is, I think we already discussed, that it is the severity of the psoriasis which mainly affects the treatment plan. As we discussed that generally in mild, we would like to give topical treatment, while in moderate and severe, we generally like to give systemic therapy along with topical therapy. If there are particular areas that impacts the quality of life, like palmoplantar psoriasis, or if it's affecting your genitalia or the face, then also the treatment is affected. Also, when the response is not adequate, then the treatment plan is changed. The third question is, what are the common symptoms of psoriatic arthritis? This is for the sir.
Yes, I think I have discussed all these
Yeah.
things. Mr. Kaushal, have you made this question? Just like, I feel, listen, someone has made MD question. Like, what are the common symptoms of?
I have not made these questions. These questions have been shared by the HiDoc team itself.
Okay. Nice. I think I have discussed everything, like the common symptoms of psoriatic arthritis and how they can be diagnosed. So this again, then there'll be, again, I need to give the entire presentation. So common symptoms, there's nothing common symptom. Arthritis, first of all, patient will have two arthritis, and sometimes the enthesitis and dactylitis, even uveitis can predate the development of arthritis. So you need to pick up those inflammatory signs for any patients having this kind of symptoms, like enthesitis is an inflammatory thing, dactylitis is inflammatory thing. Many a time dactylitis got misdiagnosed as infection. Patients are getting after courses like antibiotics. So because the red appearance and then swollen, tender, and the severe pain, and patient often feel mild fever due to the acute inflammation. So it often get misdiagnosed as infection of the digit. So you need to pick up those clinical things, that this is not an infective etiology, this is an inflammatory etiology, and this is dactylitis. So again, enthesitis that I have mentioned in a very details, like many a time patients come to you with a frozen with a diagnosis like a frozen shoulder. So every pain in the shoulder is not a frozen shoulder. Every pain in the elbow is not a tennis elbow. So you'll have to be very particular about the history, and if someone having a recurrent and repeated symptoms and they are coming with that symptoms, we need to check for other evidences of inflammation at any other sites like arthritis, even cutaneous manifestation. You need to ask for the eye symptoms, you need to ask for the family history, because the common psychology of the patient is not to tell about everything to his physician. Like when he or she is visiting to the dermatologist, he or she is very bothered about this skin problem. Like she will tell only the skin thing, because she thinks that rest of the things are not his or her job. She decides what to do and what not to do. So you'll have to upfront ask the patient, because it is not possible for patient to link the system. Like for every time I tell my patient that the skin and joint is linked, there is such an expression, हाँ ऐसे कैसे हो सकता है, ये skin के कारण मेरा दर्द हो रहा है. So the expressions are like that, so they will never be able to connect the dots, like the skin and joints are linked, the skin or eyes are linked, the skin and enthesitis, whatever you are calling plantar fasciitis, whatever you are calling in the tennis elbows, frozen shoulder, these can be part of the disease. So that awareness is very important. You need to teach your patient for those symptoms. Family history will be very important point, because many a times if patient don't have psoriatic classic psoriasis rash, what I do in my practice, like if I feel patient could be an possible psoriatic arthritis, I used to show them various pictures of psoriasis, because many a time one small plaque of psoriasis in the knee, someone having in the nettle cleft, in the below the breast. So they upfront will never tell you those skin rashes, and that used to be there for a long time. So never feel like patient what we have told in the history, like it takes 7 to 12 years many a times to develop arthritis. So they're never able to connect because they feel that skin, that small amount of skin problem is there for last 7 years, 10 years. So how can this be? It had been due to this. So they might have a joint pain earlier. So they will never be able to connect the dots. So you'll have to ask the leading question. You'll have to check for the thing. You'll check for the family history. So what are the main treatment options I have discussed? There is no point of discussing entire presentation again. I hope I was audible during my presentation.
Yes, sir. Yes, sir.
Fine. Then it is, I have discussed the treatment. If there is any specific question, then it will be, these are like MD long questions. So I expect some more clinical question. What are the potential long-term effect of psoriatic arthritis? So for psoriasis, how it is different from rheumatoid or other disease, psoriatic is many a time we find the metabolic syndrome is associated with psoriatic arthritis. So those patients are more obese. They used to be. They are more tendency of having fatty liver. Many of them are diabetic. So these overall thing are connected. So overall metabolic syndrome is associated with psoriasis and psoriatic arthritis. So in that case, you should be very cautious regarding choosing your drugs. You should encourage the patient to maintain more healthy lifestyle. So more exercise, and for inflammatory arthritis, exercise is a very important part. You can reduce your amount of drugs by doing regular exercise. You'll have to emphasize that. You'll have to teach your patient that if you do regular exercise, we can reduce your drugs. If there is no other, like someone having uveitis, you cannot do anything with doing an exercise of uveitis. You cannot do anything of skin. But for arthritis, if patient do regular exercise, that is very helpful. Role of biologic drugs play in the treatment of psoriasis and psoriatic arthritis. We have discussed, both of us has discussed. Potential side effects we have discussed. What are the recent advance in the management of psoriasis? That is, if there is any specific question, any more question is there?
No, sir. We have received these many questions from the team, HiDoc team.
Okay.
Basically, sir, the HiDoc team circulates the invitation, and it is not necessary that only rheumatologists will be attending it, but there are the physicians as well as orthopedicians. They all join this meeting. So sometimes they don't, get very much clarity from the presentations. So they ask these questions again, so they will get more clarity onto it.
Okay.
So if there is no more questions, I would like to give my special thanks to Dr. Poonam and Dr. Arga for taking out time. I would also like to give my special thanks to all the attendees for attending this meeting. So thank you very much, sir. Let's get disconnected now. Thank you.
Thank you.
Thank you, sir.
Thank you.
It was really wonderful talk, sir. Thank you, Team Cipla. Good night.
Thank you. Thank you so much. Good night.
Thank you, everyone.
Thank you.